this recording. Okay. Let's go. Let's zoom in on the picture over there. Oh man. I better leave that one alone.
It also should be set at the right size for the doctor. It should come up to the bottom of the doctor's knee, and that would be at the right height for the doctor. So when you order your table, should you choose to use this or use this technique in the health center, get a table that comes just below your knee. You can see the table is up against the wall. It's up against the wall, and it should be left against the wall. This enables the patient to be more relaxed, for they know they cannot fall off of the back of the table. So they'll be more relaxed for you in the side posture position. What we will do is we'll start with the patient. We would have the patient sit down on the table, and then you will have them crawl down onto the table and swing their legs up onto the table in this fashion. The patient should lay on the anterior 1/3 of the table. You always want to have headrest paper for them. And their foot should hang off of the table about the height of a high-top tennis shoe. The patient position that you want, like I said, is on the anterior 1/3. You want the patient to lay on the posterior portion of their shoulder. You want to line them up so that their tragus, their greater trochanter, and their medial malleolus is in one straight line. Their belly should be approximately 4 inches from the lateral edge of the table. This is the correct position, the starting position, for all of the Gonstead side posture adjustments, whether you're adjusting the ilium, the sacrum, or the lumbar vertebrae. Okay, you can turn it off, Steve. So what we have done now is we have moved the table away from the wall so that you can see from behind the patient the proper hand placements on the individual segments. We're going to begin with the different pelvic adjustments that we make. Our first adjustment that we'll make will be a simple PI adjustment. That means that the posterior superior iliac spine has gone inferior, posterior and inferior relative to the sacrum. It's a sacroiliac joint subluxation. It has gone posterior and inferior, so what we're going to do is we're going to contact the inferior portion of the PSS. Looking at this plastic model, the patient is laying in this position. Our contact point will be on the inferior portion of the PSS. This is where we want to be contacting, right here. Now, in the Gonstead system, all of our adjustments are done on the skin. We do not contact through clothing. So you need to remember that. That's the best way to make an adjustment. So that's the way we would want you to do it. The patient, again, is in the correct position. We would have the PSS, is you're going to have to expose it so that you can find it, palpate it. You want to be at the inferior portion. When you have the patient in this position, you will then roll them into you as a whole. As a whole. The whole body is going to roll into you. You're not going to torque the spine like this. The whole patient rolls into you as a whole. Since we are adjusting the pelvis, or the ilium portion of the pelvis, we want to stabilize with our thigh on the patient's thigh. We do not stand with the patient's knee between our knees. we will stand with the patient's thigh against our thigh to stabilize that patient. Our contact point, we will use our piezoform, and we're going to be contacting the inferior portion of the PSS. Our line of drive for a PI ilium in the Gonstead system is simply posterior to anterior. Posterior to anterior. Our stabilization mechanism, we're going to use our other hand, and it's going to be up under the clavicle and the first rib, right to the front of the patient. It's here. It's not up here. You do not hold up here and pull this up. You don't push on the shoulder, as you may hurt the shoulder joint. What you want to do is be anterior to the shoulder, and you're going to be pushing up on the clavicle and the first rib. You're going to have your weight on your front foot. And then what you're going to do is you're going to transfer the weight from your front foot down into the patient when you make your adjustive thrust. The doctor is going to stand at approximately 45 degrees to the table, and the thrust is going to go P to A. That would be a PI ilium. You also have a PI-IN ilium, which would be very, very similar. The only difference between a PI-IN and a PI now is we're going to be contacting the medial aspect of the PSS. So again, you're going to roll your patient into you. Since you have the IN, you're going to be on the medial aspect of the PSS, still at the inferior portion, and your line of drive for this one, your fingers are going to be going more up the spine. Your line of drive is going to be P to A, but the reason your fingers are going more up the spine is because when you torque, your fingers are going to move into the spine as you torque the ilium down the sacroiliac joint. So the line of drive is the same as with the PI. It's P to A, but the difference is now you will torque into the spine with your fingers, and it's actually torquing down the joint. Another misalignment that you'll see is the PIEX. The PIEX is where the ilium has gone not only posterior, but it has also gone external. So we're going to want to be on the lateral aspect of the PSS. I didn't demonstrate this, but for the PIIN, you were on the medial portion of the PSS, posterior, inferior medial portion. For the PIEX, you're on the posterior lateral portion. Our line of drive for this is still going to be the same as it was for the PI, which is again P to A. The difference is we will now torque up the joint. In this fashion, your fingers will exit the spine for the EX movement. So you'll bring, again, the patient into position. You're going to stabilize them into the table. The doctor's stance is the same, 45 degrees to the table, weights on your superior foot. This time, as you find the PSS, you're going to be on the lateral portion of the PSS. Your fingers will this time be down across the spine, so that when you put your thrust in, which is going P to A, you will then torque out. You'll torque up the joint as your fingers exit the spine. Another move that we will do, the pelvis can not only go PI, but it can go anterior and superior. And that means it's going to rock up the joint this way. It's going to rock up. And when it does this, we're going to want to contact just behind the acetabulum, right here. This is sometimes called the Gonstead eminence. And you'll find that by palpating the PSS, going 2 inches lateral and 3 inches inferior. And that will put you right behind the acetabulum on the acetabular ridge, also known as the Gonstead eminence. For the straight AS, our line of drive is going to be P to A on the patient, and it's going to go down the shaft of the patient's leg. Down the shaft of the patient's leg. Again, you'll bring the patient into you in the same type manner. The doctor stands at 45 degrees. The weight is on your front foot. The patient's foot is behind their knee. You can see the toes are resting right behind the popliteal fossa. The other leg is off of the table. The patient is comfortable and feels very secure and stabilized. You find the PSS, you come 2 inches lateral, 3 inches down, and you should be right here on the acetabular ridge. And our line of drive is, again, P to A, but it's also down the shaft of the leg. So it's P to A and slightly superior to inferior. And it's this way. That's how you would put the force in for an AS. An ASIN is, again, you're going to incorporate torque. And remember, when you have the internal movement coupled with the PI or the AS, your fingers are going to move into the spine as you're torquing down the joint, So since it's gone internal, we're going to want to come down again, palpate 2 inches lateral, 3 inches down. You're going to be on the acetabulum, and this time your fingers are going to be moving more up the spine in this fashion, and your line of drive is going to be P to A, S to I, down the leg. Only this time you're going to torque it this way to bring the joint back down, to bring the PSS back down the the PSS back down the sacroiliac joint. But your contact is on the acetabular ridge, but the reference point for the misalignment is at the PSS. The other one is called the ASEX, and that means that the pelvis has gone not only anterior and superior, but it has also gone externally. So when we thrust this time, we're going to want to torque down the spine. Remember, we're going to want to torque up the spine. Remember, it's this way. Your fingers are going to exit the joint. Okay. Exit the spine. You're going to have the same contact point. This time your fingers will be going across the spine, as you see. Your line of drive is going to be P to A, S to I, and you're going to be torquing this fashion, ASEX. That's your direction, line of direction, and the way you'll put your thrust in. The positioning of the patient is always the same. Always the same. Okay, next we're going to do some sacral misalignments. Oh no, let's go back. Let's do a straight IN ilium misalignment. A straight IN. That means the ilium has gone internally. And so we'll show you how to set up on that. Again, remember, it's very important that the patient feels stabilized. You want them to feel secure on the table so that they can relax. The more stable your patient is, the more relaxed the patient is, the better your adjustment will be. So for an IN, the difference with an IN now, we're going to greatly pronate that patient. And the reason is because our line of drive, we're going to be setting up on the medial portion of the PSS. Our line of drive is going to be not just P to A, but mainly also medial to lateral. So we'll stabilize the patient into the table. We're going to contact on the medial portion of the PSS. You're going to want to have your fingers running back towards you, and your line of drive is going to be P to A, but it's also going to be medial to lateral in this fashion. And that has to take out that internal rotation. The next misalignment that you'll see is the EX. And that means that the ilium has just gone straight external on this side relative to the SI joint. So we're going to contact the lateral aspect of the PSS, and our line of drive is going to be P to A, but not only P to A, it's also going to be lateral to medial. Again, same positioning for your patient. Bring the patient over. Now with the EX, your patient is the least pronated. You're going to want them as perpendicular to the spine as to the table. Their spine is perpendicular to the table as possible. And you're going to contact the lateral aspect of the PSS in this fashion. And our line of drive is going to be P to A, and it's going to be lateral to medial. Okay. Now what you need to realize is that your forearm is going to be determining your line of drive for any one of these, and I'll quickly review them all. The PIIN or in fact, let's start with the PI. The PI is just straight P to A, and you can see your forearm is P to A. The difference between the PI and the PIIN, the PIIN, your fingers are up the spine, your pisiform is on the lateral aspect, on the medial aspect of the PSS, and you're going to torque into the spine. For the PIEX, your pisiform is on the lateral aspect of the PSS, and you're going to torque up the spine as your fingers exit the spine. It's the same line of drive, just with torque. In the AS, your line of drive is P to A down the shaft of the leg, and for the IN movement, you're going to torque up the spine. For the IN movement, you're going to torque down the spine. Your fingers are going to move into the spine. For the EX movement, your fingers are going to move out of the spine or exit the spine as you're torquing up the spine. For the IN, you're going to pronate your patient more, so that your line of drive is going to be more medial to lateral and P to A. And for your EX, they will be even less pronated, and your line of drive is going to be P to A, lateral to medial, this direction. So that's a quick recap of all those moves. Next, we're going to talk about the sacrum. And the sacrum can subluxate in more than one joint. You can have a problem with the sacrum at the lumbosacral joint, or you can have a problem with the sacrum at the sacroiliac joint, and I'll show you that better here on the spine. It's either going to affect the L5 sacral joint, or it's going to affect the sacroiliac joint. The sacrum will move in several different directions. It can move just base posterior. It'll come just straight posterior at the base of the sacrum. It'll come straight posterior. And that is a lumbosacral subluxation. You can also have rotation of the sacrum will come posterior on the left, or it can come posterior on the right. We're going to be covering those particular movements. Sometimes incorporated with the posteriority, you can also have inferiority, and we'll explain that one. That would be called, in this case, a PIL. And on this side, you could have posteriority with inferiority, and that would be a PIR. So there are the various listings that we're going to be discussing right now. What we're going to be showing now is the base posterior sacrum. The base posterior sacrum. Our contact point for the base posterior sacrum is the first sacral tubercle. The first sacral tubercle. And it's the reason we want to be on the first sacral tubercle is because it's the closest tubercle to that lumbosacral joint. And since the lumbosacral joint is the level of the subluxation, that is the one that we want to be as close as we can to. If you're not sure that you're on the first sacral tubercle, you're better off to move down onto the second sacral tubercle instead of inadvertently putting the force into the fifth lumbar and making the problem worse. So again, what you're going to do, you're going to roll your patient into you as a whole. This time, you can stabilize the patient hip to hip. And your thigh is going to come up the patient's thigh. You can stabilize hip to hip on the patient. You're going to palpate the patient, and you can move the leg up and down this fashion in order to isolate the fifth lumbar and the first sacral tubercle. Once you find the first sacral tubercle, that's going to be your setup, your contact point with your PSS. Your line of drive on this is going to be P to A and slightly I to S as you reset that joint. And it will go this fashion. That's a base posterior. You also can have a posteriorly rotated sacrum, and in this case we're going to show the posteriorly rotated sacrum on the left. And what we will do with this one, we'll again roll the patient into us as a whole. We're going to find the PSS. We're going to set up just inside the PSS on the sacral tuberosity. You're going to put your pisiform right on that, and your line of drive on this is going to be P to A, but it's also going to be medial to lateral, and it's going to be slightly I to S. This is the direction here. As you look at the joint, that's the way the bone has to move as you're adjusting the sacrum back underneath the ilium. If you have inferiority on that joint, so it's posteriorly rotated on this side with inferiority, then we're going to incorporate torque to lift it back up into that position. So it would be the exact same adjustment. This again is a posteriorly rotated sacrum on the left, or a PL sacrum, but now it has inferiority, so you would call this a PIL sacrum. It's basically the exact same adjustment. It's going to go P to A, it's going to go medial to lateral and I to S, but it's also now going to incorporate torque this way. You'll torque it up the joint to restore the proper relationship within that sacroiliac joint. You can also do this adjustment with the involved side down. With this case, we would have a posteriorly rotated sacrum on the right. Posteriorly rotated sacrum on the right. That means that the right sacroiliac joint is down on the table. This is the joint we're going to be adjusting, the lower joint. And the sacrum here has come posterior on this side. So when we set up, we're going to be putting our pisiform in here, thrusting back toward the patient, I to S, in that fashion. So the involved side down works very, very well when you have a patient who is a little rounder or a little bigger than yourself. Again, you're going to roll the patient into you as a whole. You're going to find the PSS on the other side. You're going to set your pisiform right on the sacral tuberosity on the right now, because this is a posteriorly rotated sacrum on the right, and your line of drive is going to be P to A, again, medial to lateral, and I to S. And if it was a PIR, the only difference is you would incorporate torque this way. You can cut. Another way to adjust the ilium, and these are alternative moves, is Gonstead has what's called a pull move. Now, we're not going to try and demonstrate all the moves in the Gonstead system, but we are going to show the ones that we use here at Sherman College. The Gonstead system incorporates more than we have time to show here, and more, in fact, that we have time to teach at Sherman College. But the ones that we do show you and teach you are the ones that we feel will get you started with the majority of problems your patients will come in with. For the pull move in this case, we're going to address an EX on the patient's right. An EX on the patient's right. That means that the sacroiliac joint is the problem, and that the ilium has gone EX to the sacrum. Now, we've shown you how to do that with a push move. We're now going to discuss a pull move. With the pull move on the EX, and the EX, the preferred move for the EX, by the way, is the pull move. You're going to have the patient a little bit closer towards you, because you're reaching way over the patient. And you may even want the spine. The spine has to be perpendicular to the table. You will not pronate the patient. In fact, sometimes you may even want to put them a little bit past perpendicular, away from you, actually slightly supinated. Our contact point is going to be the same as if it was a push move. We're going to be for an EX on the lateral aspect in the center of the PSS. We're going to set our pisiform right in that area. You can have the patient lift up and set down, but that's the contact point you're going to have, is on the lateral aspect of the PSS. You will then bring this foot up. Your knee will be behind the patient's buttocks, and your toes, or the top dorsum of your foot, will lay up on top of the thigh, just above the knee. And when you put your force into the patient, you're going to put a thrust straight into the joint in this fashion. In. It's not pulling this way. It's not pulling. It's a straight P to A thrust. And at the same time you're doing that, you'll incorporate this motion here, which is like kicking a ball under the table. So you'll just take it in this fashion, and the adjustment would be like this. That's the adjustment for the EX. You can use that adjustment also with an ASEX, which is the preferred move. In this case, you would get way down again on the acetabulum, 2 inches lateral to the PSS, 3 inches down. you're going to be on what's called the Gonstead eminence, and you're going to, and this time, you're going to make a very similar stance and setup with the patient, and your thrust is going to go, again, P to A, only this time you're going to be torquing as your fingers are going to further exit the spine as you're torquing down, the joint. No, up the joint. I'm sorry, this way. So you're going to incorporate the kick, and the thrust is going to go in this fashion. That would be your ASEX. You can also pull an IN misalignment. Only the IN misalignment that you pull, you're going to pull it with the involved side up. And you're going to use a 3-finger pull on this one. You're going to, again, contact the medial portion of the PSS right here. But you're going to use 3 fingers, and you're going to pull it P to A, medial to lateral. Again, you're going to want to have the patient perpendicular to the table. You're going to contact the PSS, contact it with 3 fingers. That's the way I do it. You can, sometimes people will contact it with these 2 fingers, stabilizing it with the chiropractic index finger behind in this fashion. However you want to do it is up to you. How do you get right on the PSS? Your thumb will then rest up off of the spine, off of the spine. You're not going to have it down on the ilium or on the lumbars. It's just up here on the patient's flank. And you're going to have the same motion when you put your force in. Your knee is up behind the patient's buttocks, and the dorsum of your foot is on the femur portion just above the knee. And your line of drive is going to be P to A, but it's also going to be medial to lateral as you're putting in your counter thrust with your leg to stabilize the patient into the table. That's the way that adjustment would go. Another very popular pull move is the sacrum being posteriorly rotated. And you would do that with the involved side up. So in this case, this patient's left side is up. This would be the right position to adjust a posteriorly rotated sacrum on the left. It would be very, very similar to setups to the other pull moves with the patient positioning and doctor stance, except your contact point is going to be on the sacral tuberosity between the PSS and the sacral tuberosity. You're going to be on the sacral tuberosity, and your line of drive with this is going to be P to A, slightly medial to lateral. You need to make sure that you're on the sacrum, not on the ilium, and that's the way your force would go, like this, into the joint. That's the way you would do the pull moves in the pelvis. You can also do pull moves in the lumbars. We might as well do that since we're here talking about the pull moves. The lumbar vertebrae can rotate PL or PR. You should be familiar with the listings by this point. If we had, in this case, a patient who had a PRIM, our contact would be on the mammillary with the involved side up. So it was a PRIM. The vertebrae has rotated to the right. The high mammillary is the one on the left, and that's the one we'll be contacting. You will contact that. You're going to find the mammillary of L5, you're going to count up to L4. You're going to come just lateral to the spinous of 4, and you're going to put your fingers right on the mammillary process. You may either do 2 fingers. Some people like to put 1 finger on it. I like to use 2 fingers, and usually these 2 fingers I'll use, my index finger and my chiropractic index finger. 1. You find 5, you come up to the spinous of 4. It's lateral to the inferior 1/3 of the spinous of 4. You're going to be right on the mammillary of 5. You're going to, again, push the patient under just a little bit so that they're at least perpendicular. Set up on the mammillary process, and your thrust is going to go, again, into the spine, and this time you'll incorporate torque as you thrust, this way. And that should make that adjustment for you. If you had a PR or PRS, and the spine was particularly military, or had, military is not the right word, but a hypolordosis in that area, or if the patient happened to be in extreme discomfort, you can use a pull move on the spinous process, which would give you more speed and hence make the adjustment easier for your patient to take. So the patient, if we had a PR, You set up on the spinous processes, and I like to grab the spinous process using these two fingers with my chiropractic index finger behind them, stabilizing them. So you find the spinous process of 5, you set up, and your thrust again is going to go P to A with a little bit of medial to lateral as you set the vertebrae back in motion in this way. That's basically the pull moves. Now there are more pull moves than that, but that's basically the ones that we use here at Sherman College. We're going to move up the spine into the lumbar spine, and what we're going to do is have our patient turn over for the lumbar adjustments. So when the patient gets up off the table, have the patient walk up off the table and swing their legs over like a pendulum, and that changes the weight mechanism and helps the patient to get up. Always let your patients get up and down on their own. When a patient is in pain, they're not going to want any help. Set your patient up in the exact same way on the anterior 1/3 of the table. The bottom leg will be hanging off the table about the height of a high-top tennis shoe. The toes will come up behind, the dorsum of the foot will come up right behind the popliteal fossa. You're going to have the patient's head straight. Always use headrest paper. Remember, the #1 rule in chiropractic is always be nice to your patient. So we have the patient in this situation, and this is how we're going to demonstrate the lumbar adjustments. In the lumbar adjustments, you have the main contact point will be your spinous process. In fact, in all the Gonstead work, the main contact point within the vertebrae of the spine is the spinous process. You have alternative contact points, and they will be designated by dash listings, like a PLI dash, PRI dash. And in the lumbars, the dash would be for a mammillary, and that would be your alternative contact point. If we were adjusting this patient's fifth lumbar, you need to remember, in fact, for all the segments in the spine, from C2 all the way down to L5, the line of correction is always going to be basically the same formula. Your contact point, you will thrust through your contact point through the mass of the vertebral body in the plane line of the disc. So if you're contacting the spinous process, you're going to be aiming right at the center of the vertebral body of that segment. And then, as you're aiming through that portion, then what you're going to do is take into consideration the line of the disc. So when you get in the lumbar spine, you're going to have a little bit of S to I characteristic in your line of drive. In fact, as you go through the spine, we'll show in just a moment. In fact, let's show it right now. Can you turn onto your belly for 1 minute? Your line of correction in the spinal column, due to the curves that are in the spine, will be in this fashion. You're going to have your line of drive. It'll go in this direction. The discs are slightly S to I in the lower lumbars. At L3, your line of drive is pretty much going to be P to A. As you continue up the spine, when you get up into the upper dorsals, lower dorsals, upper lumbars, you're going to have a little bit of I to S in your line of drive. And as you continue up the spine, your line of drive will follow through the plane line of that disc, pretty much P to A. And when you get up into the upper dorsals, you're going to have a little bit of S to I line of drive. And then in the cervicals, a little bit of S to I in the bottom, straight on in the rest of the spine. Maybe a little bit of I to S up at C2 area. But you have to remember the contour of the spine and the way the discs are in between the vertebrae. Remember, the Gonstead system, the line of correction is always through the mass of the vertebral body and the plane line of the disc. So, when we set our patient up, we're going to be doing a lumbar adjustment, and in this case, we'll set up for a PLI, or no, let's do an alternative contact, a PLI-M. So that means we want to be on the contact. We want to contact the mammillary on the right, the PLI-M. That means the spinous process has gone to the left, and the disc is wedged open on the right. So it's going to be a PLI-M. We're going to come down. We're going to palpate the lumbar of L5, the spinous process. We're going to go up to the spinous process of L4, At the inferior 1/3 of the spinous process of L4, we're going to contact the mammillary process. What we will do here is we're going to pull this big muscle, the erector muscle, up out of the way so that we can put our pisiform unhindered right on that mammillary process. You're going to be stabilizing the patient hip to hip, and your line of drive is going to be P to A. You want to have your forearm pretty much parallel with the table. So you're going to go P to A through the mass of the vertebral body and the plane line of the disc. So it'll be P to A and slightly S to I this way when you put your force in. And you'll have to incorporate torque to close that wedge, and the torque will be this way, torquing down. If we were going to contact for just a straight PR or PRS, our contact point is going to be the spinous process. So again, you're going to contact the spinous process of L5, and this time you're going to set up on the spinous process. I think you should be pretty much, just slightly below the center of the spinous process. And you're going to put your line of drive in is going to be P to A, and it's going to be slightly S to I. If it was a PRS, you would torque it down. If it was a PR, you would just put the line of drive straight in with no torque. Remember, your forearm is always going to indicate your line of correction. When you move up the lumbars, if we were moving into L2, L1, let's assume that we're going to adjust L1. In the Gonstead system, the side posture adjustment for the lumbars is generally going to be used in the lower lumbars, L4 and L5. You can continue to adjust L3, L2, L1, even T12 side posture, but that is generally recommended to be used in the prone or in the knee chest position. What you need to remember when you're adjusting in the upper lumbars is you're going to have a different line of correction. Instead of having the S to I line of drive, you'll have to incorporate a little bit of I to S. So we'll just show one of those. Let's say we're going to do an L1 adjustment, and if we had L1, then it has gone P, L, I-M. So we're going to have to palpate up to T12. We'll find 5, 4, 3, 2, 1. We're going to find the spinous process of 12, come just lateral to the spinous process of 12, and our line of drive is going to be P to A through the plane line of the disc, and it's going to now have a little bit of S to I in its line of drive through the plane line as you're torquing it down this way. Next, what we're going to do is we're going to go to our prone adjustments, and we're going to do that on the high-low table.
My foot piece so they can see.
I will. Shh. Okay. What we're going to do now is we're going to show you the single-hand contacts of the Gonstead system. And at Sherman College, for the Gonstead single-hand contact, we will use at Sherman College the high-low table. The positioning on the high-low table is going to be, again, the same for each one of your adjustments. You're going to have the patient laying prone on the table. You're going to elevate the ankle piece. This will help relax the back musculature. You're going to have the head in extension, as you can see here. It will not be flexed. It'll be slightly in extension. And we will, for these adjustments, we will incorporate this sag mechanism so that this will lower down away from your patient. This will open up the anterior portion of those joints to allow your adjustment to be much easier on your patient and with a lot less force. The prone position for the Gonstead single-hand contact, the adjustments, you can adjust any segment of the spine with this, any segment. And at Sherman College, we basically use this up through the thoracic spine. We don't go into the cervical spine. But we're going to demonstrate from the thoracics down through the pelvis. We'll start with our upper thoracic adjustments. Single hand contact. What you're going to see here on the patient The contours of the spine, and remember we spoke about them, it's important that you understand the plane line of the disc with the patient. So when we're up in the upper thoracics, we're going to want to take that kyphosis into consideration, and our line of drive is going to have some S to I in it. In the center of the thoracic spine, it'll be basically P to A. When you have it in the lower part of the thoracic spine, not only will it be P to A, but it'll also be slightly I to S. The main line of correction for all Gonstead adjustments is posterior to anterior. We're going to demonstrate basically from T3 to L3. What you'll do, in fact, we'll demonstrate from T1 all the way down to L3 at the moment. And on these adjustments, I'm going to recommend that you use your superior hand. Use your superior hand as your contact hand. So we'll just start, let's say we're going to start at T2, and we're going to do a T2 PL. Our line of drive for a T2 PL is going to be P to A through the mass of the vertebral body and the plane line of the disc. You need to remember that. So whatever your contact point is, that will incorporate your line of drive. So if it is slightly PL, the bone, you'll contact the spinous process, and your line of drive will have a little bit of medial to lateral. It will not be like this. Your line of drive will just be slightly medial to lateral as you're pushing through the spinous process through the mass of that vertebral body. So if you're going to set up on a T2 PL, you always count down to the segment. Don't use landmarks. Landmarks will not take you where you want to be. So you're going to set up right on the spinous process. You want to be as close to the spinous process of T1 as you can. You're going to stand with a squared stance, and your pisiform, your episternal notch is going to be just over top of the contact point, and your line of drive is going to have some I to S in it. As you lift the vertebrae, set it onto the disc, and your thrust is going to go through the plane line of the disc through the mass of the vertebral body. So your adjustment is going to incorporate a body drop and a sustained thrust, and it'll be in this fashion. That's how you would do that. Now you could see when we did that how the patient's head came back. You don't want that to happen, so you can have an assistant to hold the patient's head, or you can rest your forearm on the patient's head when you put the force in, and you can see the head stayed much more stable. You're going to continue with this throughout the spine. It doesn't matter what segment that you're on. If you wanted to adjust, let's say, a PLS T6, again, you're going to palpate, find the right segment. You're going to be on T6. If it was a PLS, you're going to get as close to the spinous of T5 as you can. You're going to set your pisiform right on the most superior aspect of the T6 spinous as you can. If this was a PLS, we're again going to be thrusting through the mass of the vertebral body and the plane line of the disc with a little bit of a motion to lift it up onto that disc, and then you're going to have to torque it down. So you're going to have your knees bent. It's a body drop through the knees, and your thrust is going to come through your shoulders, through your triceps, and you're going to not only lift and thrust through the plane of the disc and through the mass of the vertebral body, but you'll incorporate torque. And it would be in that fashion. That's how easy it is to make an adjustment. When you're setting up on the spinous process, the single hand contact, you do not use a high arch. You do not use a high arch. This is not the way you would set your hand on the patient. It is a flat hand contact, concentrating the force through the pisiform. Through the pisiform. You can continue that all the way down, and in fact I recommend you continue to use that superior hand all the way down to the third lumbar. All the way down to the third lumbar. When you get down into the lumbar spine, in order to make sure you're on the right segment, you can count from the top down, which I recommend, and you can count from the bottom up. So if we were going to be adjusting the third lumbar at this point, what we would do is we would engage the sag mechanism so that it would lower the patient. So that you can raise and lower the patient in this fashion. You can isolate the fifth lumbar spinous, the fourth lumbar spinous, the third lumbar spinous. What you're going to do is you're going to count up 5, 4, 3. You're going to put your pisiform right on the spinous process, and your line of drive is going to be through the mass of the vertebral body. You can see how the table drops down away, and that's the sag mechanism. That's what it's supposed to do. That sag mechanism needs to be incorporated for all the adjustments. You couldn't quite see as much of the movement up in the thoracic spine, but you can see more of it here. And so your line of drive is going to go, again, through the mass of the vertebral body and the plane line of the disc. Your stance is going to be squared, and you're going to set the vertebrae right into position, just like that. It's a nice, easy, quick thrust. When you are doing an alternative contact, and you're going to be adjusting, well, let's just say we're on a T8, and you want to do a T8, and you want to do a PRI-T. You're going to palpate down to T8, and you're going to find the transverse process of T8. You're going to have to climb up above the spinous process of T7, and you have to remember the imbrication that takes place within the thoracic spine. And you'll palpate till you find the transverse process of T8. As you find the transverse process of T8, you're going to set your pisiform right on there. There's not a tissue pull, just set your pisiform right on it. And when you make your correction, your fingers are going down the spine. They're not crossing the spine as they were with the spinous contacts. They're going straight down the spine. And our line of drive on this is going to be, again, through the mass of the vertebral body, but we're going to be exposing our pisiform now. So our thrust is going to be in this fashion. As you're moving that spinous process, the transverse process down in the right position. I'm going to try to demonstrate that on here. This is our transverse process. Gonstad's not so much interested with the rotation. We don't want to just twist the bone. That's not what we want to do, just twist it. We want to actually move the bone back into its position. So hence, when we put our thrust in, we're going to be exposing our pisiform like this as it pushes the bone back underneath. I don't know if you can see that on the camera or not, but it needs to go back underneath this way. And that's what we mean by exposing the pisiform. So, unlike the transverse process adjustment where your fingers cross the spine, your fingers will stay on the same side of the spine, and you're going to expose your pisiform to push the transverse process back under the vertebral body, and you're going to torque it down to set the vertebrae into its normal motion so that the body can restore to its normal position. So that's the single hand contacts for L3 up to T1. When you're getting in the lower lumbar spine, you're going to switch and use your inferior hand. So if we had an L4 that we wanted to adjust, and it was a PL L4, we would, again, move the sag mechanism up and down. We'll use the inferior hand. We're going to look at the fourth lumbar, and we're going to say that we have a PL. To find L4, gauge the sag mechanism so that it raises and lowers so that you can isolate the difference between S1 and L5 and L4. Once you find the spinous process of L4, remember, the spinous contacts, your fingers are going to cross the spine. A nice flat hand, no high arch, and you see my hand is crossing over the spine for a PL. The line of drive is going to be P to A through the mass of the vertebral body, through the plane line of the disc. And as we're putting our thrust in for the PL, we're also going to have to now incorporate a little bit of S to I in our line of drive. And the sag mechanism would be incorporated. You want it to have a little bit of tension underneath the belly so that it gives a little bit of support, and your thrust is going to go that fashion, right into the bone, and it's a nice, easy adjustment. If you were going to be doing a PRI-M on the fourth lumbar, again, you're going to use your inferior hand. You're going to be finding L5 spinous, L4 spinous, then you have to find L3 spinous, come just lateral to L3 the lower 1/3 of the L3 spinous, your fingers will not cross over the spine, and you're going to put your thrust in again through the plane line of the disc, through the mass of the vertebral body, and this time you will be torquing down. And you'll expose your pisiform as you're moving that vertebrae, rotating it back down underneath. I'm going to show you how to do the Gonstead double thenar from L5 through T11. And the way we're going to do this, you're always going to stand on the side of the high mammillary, the side of the high mammillary. Again, you will engage the sag mechanism. You will engage the sag mechanism. So let's say we have an L2 that has gone PRI-M. So what we're going to do is we're going to come up, we're going to palpate L5, 4, 3, 2, 1, and then you're going to come just lateral to the inferior 1/3 of L1. You're going to set up with this portion of your thenar process on the mammillary of L1. You're going to set it right on that. This hand is going to come around just to stabilize. The force will not come through your stabilization hand. The sag mechanism will go down. You'll be in this type of a position. Your shoulders will be squared up with your patient's shoulders, and you're going to drop, and you will torque at the same time as the force comes in through this bone, this way. And your patient will move up a little bit when you put your thrust in, this way. That's how the force goes in. And you can do that throughout the lumbar spine and into the upper dorsal, into the lower dorsal spine, and it's the same mechanism for an alternative contact. Remember, stand on the side of the contact point, find your contact point, you set your thenar right on it, stabilize with your other thenar, engage the sag mechanism, and just thrust through your contact hand, stabilizing with the other hand. That's pretty much how you're going to do Gonstead through this portion in the prone position. Next, we're going to show the cervical chair adjustments and how to do those cervical adjustments. This is the Gonstead chair. This is the chair that we use to make the adjustments with the patient in the seated position. Again, you can see it's covered with cloth to keep the patient from slipping. The back of the chair is adjustable. It can lay all the way down, and it's very good that it lays down like that, because that helps you to do a seated examination of the patient's entire spine. In the Gonstead system, we like to examine the patient seated so that we have the spine under weight bearing. We feel it gives us a better representation of what's taking place within that spine when, while it's subluxated. When you look at the back, you will see that there is a little block here, and this back rest mechanism will rest in any one of these notches. You can see. We recommend that when you're doing cervical chair adjustment that you keep it in the most upright position. This is the shoulder strap here. You will use this to stabilize the patient. When you're making your adjustment, you will always stabilize the opposite shoulder. I'll show you how to use that on the patient in just a moment. The snap side stays snapped, and you just use the Velcro portion, tighten to release the patient. There's usually 2 snaps, so if you need a shorter strap mechanism for like a child, then you have that. If you have a larger patient, then of course you put it on the snap that allows the strap to be its longest. When you have the patient come and sit on the chair, and by the way, this is one of our interns, Lisa Klopp. She's volunteered to help out. You're always going to have the patient sit as upright as possible in the chair. Your next step, you're going to have the patient rest their hands comfortably in their lap, and you're going to have them put their feet out in front. You want their toes up off of the floor. Can we show this? Can you show all the way down? That's right. You want their toes up off of the floor. Some people like the toes like this, and that is fine. I just recommend that you at least get the toes off of the floor. You don't want the patient like this. So remember that. Okay, so they're in the seated position, comfortably sitting nice and relaxed. What we're going to do is we're also going to show you the hand position for the doctor. But in order to make the right contact for your patient, This is the point that we use as our contact point. It's this portion of your finger, your chiropractic index finger. It's this tip. It's not exactly at the very top of the finger, but more towards the thumb side. So if we looked at the finger from this side, it would be this portion of your finger that you're going to be using as your contact point for your patient right there. And that's what we're going to use whenever we adjust anywhere from C2 down to the third thoracic segment. For the C2 to T3 adjustments, the doctor is going to stand with his feet in between the legs of the chair. So I'm going to have you get up for me for a minute, Lisa, and I'm going to turn the chair this way and see if you can pick this up for us, Steve. The doctor will stand with his feet in between the legs of the chair. You don't want to be outside of the legs of the chair. You want to be within the legs of the chair, and that's if we had a line here and a line here. You want to stay within these lines. When you're setting up on your patient, you're going to want to have your contralateral foot forward. And what I mean by that, if you're going to contact your patient with your right hand, then your left foot should be forward. If you're going to be making your contact with your left hand, then your right foot would be forward. Okay, come on back over, Lisa, and have a seat for us. The doctor's hand position, you're going to want to try to keep your thumb in a straight line with your radial bone. The palm of your hand will be perpendicular to the floor, and the fingers will be parallel to the floor. This is the basic hand position for making a Gonstead adjustment. The Gonstead adjustment is a very simple thrust. It incorporates a little bit of a lift. I'm going to turn sideways so you can see. The adjustment starts here. The doctor's elbow is in towards his body, and the thrust incorporates lift and torque. It's very simple. It's just like this. That's the Gonstead adjustment in simplicity. Of course, it has to be done with a great speed to do that. The stabilization hand, on the other hand, will be out stabilizing the patient's head, and the elbow of the stabilization hand will be pointing. If this was a big clock in front of me and I was stabilizing with my left hand, my left elbow would be pointing up at 10 o'clock. If I was stabilizing with my right hand, my right elbow would be pointing up at 2 o'clock. And that's how you would stabilize your patient, as you're going to see in just a moment. We're going to consider that this patient may have a PRC2. PRC2. Can I have that spine, please? In the cervical spine, you'll see that there are bifurcations to the spinous processes. The spinous processes are not just one solid piece, but they're in two. And so if whatever side you're going to be contacting of that spinous, for instance, we're doing a PRC2, we want to be on that right bifurcation. So the setup will look just like this. I'm setting up with that portion of my fingers, you remember, right on the right bifurcation. And that's where you're going to be making your adjustive thrust. And remember, again in Gonstead, I sound like a broken record, but the line of drive is always going to be through the mass of the vertebral body and the plane line of the disc. So that's what you have to visualize when you're putting your thrust in. The doctor stands behind the patient. The best thing to do is to take the patient's chin and put it between these two fingers, right between your index and your chiropractic index finger, in this fashion. Okay? That way you'll have full control of your patient, and you'll know how to move them. But just before we do that, since we're adjusting with a PR, I want to remind you, we want to stabilize the patient. So we're going to take the strap, we're going to undo it from the Velcro side, we're going to bring it down over the patient's left shoulder, because that's the one we want to stabilize, bring it underneath the right arm, and that's the way we're going to stabilize this patient on the chair with the strap. We're going to then come up underneath the patient's right bifurcation of C2. The patient's head will be flexed, and you'll be able to find it. Just palpate down, find C2, put this portion of your finger right up under that right bifurcation, just like this. This is the position you want. Then you're going to bring the patient's head back to you. Again, see how I have her chin, and I'm going to lift her chin. And as I lift her chin, I'll feel C2 move. Now C2 moves right there. Once it moves, I'm going to cock her head straight over onto my awaiting thumb. And you can see here that I have an opening that's right in between these right here. This opening is called the rad hole. It's very important that you maintain that rad hole so that you don't turn this into a rotary adjustment. And your thumb is going to come right anterior to the tragus. So this is the way you'll hold the patient's head for a C2 adjustment. Your elbow will be into your body. You're going to take your hand. You're going to then just rotate right around. Your thumb's going to stabilize down on the patient's chin. You're going to put your little finger and your ring finger up under the occiput, and these two fingers will go down the neck to stabilize. And your adjustive thrust is going to be P to A through the plane line of the disc and the mass of the vertebral body, just like this, with torque. That's the way you would do a PR C2. If we were going to do a PL lamina on C2, then what you would have to do, again, you would find the spinous process of C2, and this time you would just step right around the spinous process onto the onto the lamina of C2. Once you have found that, again, you're going to lift the patient's chin. When C2 begins to move, you're going to bring it right over onto your awaiting thumb. Keep maintaining your rat hole. Bring this right around, and your line of drive, keeping the patient's nose right in center. Your line of drive is again going through the mass of the vertebral body in the plane line of the disc. You can see that my elbow is into my body. You always want to make sure that that's the case. Into your body. You follow the same mechanism throughout the spine. I'm going to get the patient up and I'm going to turn them around just 1 second to show you how you may want to get a little better contact in the lower cervical upper thoracic spine when you're making this adjustment. If you're going to be adjusting a C7 or a T1, what you would do then in these cases is you may, with your other hand, with the patient's head flexed, take your thumb and just take a little tissue pull up to that bone. And then when you rest your hand, your adjusting hand up to it, you get a nice firm contact on there. Now the contact has to be light enough that it doesn't irritate the patient at all, but firm enough so that you know where your contact is stable. If we were going to adjust a PR on T1 in this case, again, we would stabilize the opposite shoulder with our strap, come up, take our tissue pull right up to T1 to tighten the tissue just a little so I can get a nice firm contact. This time, I'm going to bring the patient's head back. My fingers are underneath the chin, and I'm going to slowly raise the chin until T1 opens. You can see the patient's head had to come up higher because we're opening the joint of T1 down here. We're then going to laterally flex the patient's head over onto our waiting finger. You're not rotating the head when you do this. It's just a straight lateral flexion, keeping the nose in the center. You're going to stabilize the patient the same way on the chin, and 2 fingers under the occiput, your chiropractic index finger and your index finger going down the neck to stabilize, and your thrust is going to have lift, and it's going to be torque, just like this, right through the spinous to the plane line of the disc to the mass of the vertebral body. Okay. Alrighty. That's basically how you'll make all of your adjustments. You must be very careful in the cervical spine when you're making your adjustments because the spinous processes are so small. That's one reason why the Gonstead system is so effective. It's much easier to get this portion of your finger up underneath those spinous processes to make a specific adjustment than it is maybe to get a piezoform or something else in there. You can see by looking at the dry spine how close the spinuses are. And you can see that it's very easy for me to wedge my finger up underneath there. The patient's head would first start off flexed. You find your contact point. and then you bring the patient's head back like this, laterally flex them over onto your thumb, and you're ready to make your specific adjustment on that vertebrae to move it in the exact direction you want it. It's a very, very specific method of adjusting the cervical spine. That's the same mechanism you'll use from C2 all the way down to T3 in the chair. You don't have to go all the way down to T3. Some people are very uncomfortable with that. So then you could always take T3 in the prone position. But that's just another way of doing it depending on how large your hand is and the size of your patient. Gonstead also does atlas adjusting in the chair. He also does it in the chair. He also uses a knee chest table to adjust the atlas and the lower cervical spine. But what we incorporate here at Sherman College is the chair adjusting. To make an atlas adjustment, I'm going to turn the chair around just a little bit. The doctor is going to then step outside of the legs of the chair. Can you move that down a little bit, Steve, so they can see my feet? Remember I was telling you you needed to remain within these lines here for your lower cervical and upper thoracic adjustments. But for your atlas adjustment, you can step outside of that line now, and that's where you're going to stand for your patient. What you will then do is, the basic position for this is you'll just take the patient and you're going to rest their head against the outside of your body right here so that they're nice and stable. I'll show you that from another direction. And this is the basic position for an atlas chair adjustment in the seated position. Okay, when we're doing the atlas adjustment, it's important you remember your contact point. If this patient had an ASR atlas, our contact point is going to be on the anterior portion of the transverse process, the anterior portion of the transverse process, which is going to be anterior to the SCM muscle. You can see the SCM muscle. You want it to be anterior to the SCM muscle. And your contact point is going to be this part of your thumb right here. So you're going to put your thumb on the anterior portion. Your hand will be in this position when you're all done. Your thumb is going to be into your hand. You do not want to try and make this adjustment with your thumb out like this. You want it to be in snug to the palm of your hand. So then you're going to turn your hand supine, and you're going to contact the anterior portion of the transverse process. You can pinch the SCM muscle. Just pinch down on the SCM muscle, and then you're going to laterally flex the patient's head over to you, and you're going to stabilize down the neck on the other side. Again, you're going to want to use your strap to stabilize the opposite shoulder when you're putting this adjustive thrust in, and the patient stabilized against you, and you will thrust straight across. The line of drive is going to go lateral to medial. You can incorporate a little bit of A to P in your line of drive, but it's not always necessary since you are on the anterior portion of the transverse process, and being on the anterior portion of the transverse process will naturally take out that anteriority, which is described by the first letter of your listing. Okay, let's turn you around again and face this way. So we have the patient in this position. Let's say that we have an ASLP now. Again, it's going to be the exact same contact point. Again, you are on the anterior portion of the transverse process. The anterior portion. The difference between the ASLP and the straight lateral ASL is you're now going to turn the patient's head away. So you'll have the patient sit in here. You're going to palpate the transverse process. When you find the transverse process, you're going to place your pisiform on the anterior portion of the transverse process. You're going to bring the patient's head over to stabilize him against the outside of your body. These thumb is going to be on the chin. These fingers are going to be coming down the neck, stabilizing the axis and below. And your line of drive is going to be straight across this way. That's how you make the adjustment on your patient. Again, your stabilization in this case is going to be on the other shoulder. So you're going to keep the snap side down, and you'll just put it underneath that arm and come up on this side. So your ASLP, again, I want to go over it. You're going to be on the anterior portion of the transverse process. You're going to laterally flex the patient's head over towards you, stabilize him against your body. And I think I forgot to say, you need to turn that nose just slightly out of center for the ASLP as you make your line of drive straight across. Remember, for the ASLP, the nose is slightly turned away from your contact hand. Line of drive goes straight across. The line of correction is the exact same whether it's an ASL, an ASLP, or an ASLA. It's always the exact same. Now, if we're going to do an ASLA, we're again going to be in the exact same position. It's always the same. It's very consistent in the Gonstead system. The only difference is, after you find your contact point, which is on the anterior portion of the transverse process, ahead of the SCM muscle, you're going to pinch on it. You're going to laterally flex the patient's head over towards you. And this time, you're going to turn the head just slightly toward your contact hand, slightly toward your contact hand. And your line of drive is going to go, again, straight lateral to medial. Like I said, if you wanted to, you could incorporate a little bit of A to P in the line of drive, but because you're contacting the anterior portion of the transverse process, that anteriority will probably be picked up that way. So that's your atlas adjustments, your ASL, your ASLA, and your ASLP. That's the only difference is the patient's head position. Okay. Gonstead also addresses occipital disrelationships, or occipital subluxations, I should say, when the occiput is not sitting right in relationship to the atlas, and the atlas would not be the considered adjustment or corrective segment to adjust. And these situations may arise. When you're going to adjust the occiput will go in a variety of directions. It can go posterior and superior. It can go posterior and superior to the right. It can go posterior and superior to the left. It can go posterior and superior to the right and anterior. It can go posterior and superior to the right and posterior. There's so many different ways it can go, and these are the ways we're going to address them. So you have to consider the occipital condyles on here. They sit in this fashion. So if the occiput is coming posterior, because of the shape of the condyles, it's either going to go posterior and superior to the right or posterior and superior to the left. I don't believe it's ever going to come straight posterior. It's just going to come PS, and if it's superior on the right, that would be called an RS, PS, RS. And to correct that, our contact point is going to be right here. Can you zero in on this, Steve? It's going to be right here on what's called the mastoid groove. You'll see there's a little shelf right here. And our contact point is going to be right here on our thenar. Again, it's going to be close together. Your thumb is going to be into your thenar. And what you're going to do is you're going to pull up on the patient and stabilize right on there. And you can actually pinch right down on there, and your other fingers will come up right up underneath the occipital shelf. So for a PSRS, you're going to laterally flex the patient's head. You're going to come up. You're going to stabilize. You're going to contact right on that mastoid groove. You're going to bring the patient into this position. You're going to stabilize down the neck, and your line of drive is going to be across and down as you're setting the occiput right back on top of the atlas this way. Okay? That would be a PSRS. If you had a PSRS-RA, you would have to turn the patient's head toward your contact, because the occiput has gone anterior on this side. The idea is now to bring it back onto the atlas. So when we put our thrust into the patient on this one, you'll see when you put the thrust in, the head comes back towards center as it brings the occiput back onto the atlas. When you're doing these adjustments, again, you always want to remember you're going to stabilize the opposite shoulder. So if I'm adjusting the occiput from the right, you're going to want to stabilize the left shoulder. If you're adjusting the occiput from the left, you're going to stabilize the right shoulder. It's that simple to use this strap mechanism. If you had a PSLS, LP, what you're going to want to do now is you're going to want to come up, contact right on the
Mastoid groove.
Mastoid groove, thank you, with your thenar, and you're going to stabilize. This time you're going to turn the patient's head slightly out of position, and when you put your adjustive thrust in, you'll see that the head will turn away in this fashion. This hand does not put the thrust in. This hand is strictly for stabilization, and thrust comes this way. You have to remember that. It's never a counter thrust in the Gonstead system. It's a stabilization hand, nose comes out of center, and the thrust is just straight across, and you'll see the nose will move in the direction that the skull is going. So that's how you would do the occipital adjustments, the PS, the PSLS, PSRS, with the different rotational considerations. The occiput can also go in the AS position. It can move anterior and superior. And it can go straight anterior and superior because of the way the condyles are shaped. It can just wedge straight forward. But it can also wedge straight forward and go off to the right, or straight forward and wedge off to the left. And it can still have rotation. So it can go straight forward, it can go to the left, and it can rotate posterior, or it can go straight forward, wedge off to the left, and go anterior on the atlas on that side. Or, of course, the opposite on the right side. So for a straight AS adjustment, this is one time in the Gonstead system that we're actually going to be adjusting from the anterior to the posterior position. Since we're going to be trying to set the occiput back onto the atlas, we need to have what's called a condyle block, and we have them here in the health center. And you can stabilize the patient's occiput with these. The patient's atlas with these and the lower part of the You're going to set this square portion right up under the occiput so it's firmly up against the atlas so that the atlas does not move when you put in this corrective thrust. So what you're going to do, since the occiput has gone anterior and superior, we want to bring it back this way. Our contact point is going to be on the glabella just above the nose right here. And you can use for your contact point, you can use the center of your chiropractic index finger, this portion, and or you can use your piezoform. So it's either going to be this portion right here, or it's going to be your piezoform, and you're going to set it right on the glabella. If you're using your piezoform, it's in this fashion. Your piezoform goes on top, and you can use your right hand or your left hand first. You're going to squeeze the patient's head to stabilize it, and your thrust is going to come through in the same direction that your forearms are. It's going to come P to A and slightly S to I, straight back this way. And that will bring the occiput back on. You can also, like I said, use this portion, and you'll set that right. Piezoform, you're right on the glabella. You're stabilized with your other hand right over top of it. You will squeeze the patient's head, keep your elbows into your body, and your thrust is going to come in this fashion as you set the occiput right back down onto the atlas. If you